Okay, hi everybody. So today we're going to talk about the last bit of the basics, and that's the zones of the ECG. So when we talk about zones, what we are talking about basically is that, well, let me just explain it to you in this way. I'm just going to put the video panel up there. So basically, like we said, the ECG is looking at the heart from different points of view. So it's kind of like me getting 12 of you and putting all around me. Everybody will be standing from a slightly different point of view and giving a description of my face. And when you give a description of my face, you are just giving from your point of view, but put them all together, and that's when you get a full picture. However, if I, for example, were to put three people in front of me here, their description of me would be similar, but not exactly the same because they form one zone. And then if that's comparing to somebody who's at the back, they'd be giving a completely different description of my head. And somebody who was there would also be sharing a similar description with them. So in other words, we're trying to group leads together so that we know that these leads look at a similar part of the heart. And we must know which part of the heart because that's what helps us. That's what's helping us to actually decide where things are happening in the heart. And this is more in terms of ischemia and knowing where things are going wrong. Okay, so that's what we're going to cover today. All right, let me just hide that video panel for now. All right, so let's look at them. So basically the heart views, the ECG views the heart in two planes, okay? So you've got the coronal, and that's where the limb leads orientate themselves around this plane. And then you've got the axial, which means, and these are your precordial leads. In other words, the ones that uh, go around the heart on the chest, okay? So this is how your limb leads are orientated, okay? Let's just spotlight this for a second. All right. So if we had to look at our heart, these limb leads are essentially, if you can, let me just try and do a drawing over here. So if you can imagine a circle around, let's put a circle around the heart like that, all right? Let's say, let's expand it a little bit. No, let's drop it there, all right. So let's say, for example, there's a circle going around your body like that, and that's the heart. So each of these leads is looking at it from that particular point of view. All right. So let's put something on there just to make it a bit more apparent as to what we're talking about. So for example, AVL kind of sits more or less at the top here where it's showing in there. And lead one sits there. So you can see the two of them are looking at a similar part of the heart, whereas leads 2, AVF, and 3 are kind of looking at this side of the heart. And then you've got poor old AVR just on his own or her own, sitting on that side. Okay. So these are kind of like looped around the heart in that direction. Okay. So you've got AVL and lead 1 that are looking at this side of the heart. And this is called the lateral edge. So they are called the lateral leads. And to be more specific, they are called the high lateral leads. AVR is the only one that looks at the heart from the right-hand side. So it's one lead that's on its own. And then you've got leads 2, 3, and AVF that are looking at the heart from the bottom. So these are called the inferior leads. Okay, I hope everybody gets that. All right. Okay, so let's just move ahead a little bit. Okay, so let's just revise it one more time. So one group that we have is lead 1 and AVL. They are both looking at the high lateral side of the left heart. Leads 2, 3, and AVF are looking at the inferior border of the heart, and lead AVR is looking at the right-hand side. Okay, very good. Now, what that means is that whenever we are looking at the leads 2, 3, and AVF, we are looking at the inferior side of the heart, and they tend to give you a similar picture. Not exactly the same, but they always tend to look similar. That's the thing. Okay, so these three give us sort of a similar picture. And when we are looking at the inferior side of the heart, then we look at leads 2, 3, and AVF. And they are the ones that give us that idea of what's going on over there. Okay. All right. So like I say, AVR looks at the right side of the heart. It's often called the forgotten lead. And the truth is that it has a few uses. Some of them we've actually covered in some of our lectures, but it would be nice for you if you have time, go have a look, read up about AVR. It's actually quite interesting and it can help you quite a bit as well. And then we have leads 1 and AVL. So these look, as we said, as at the left lateral wall, and they are referred to as the high lateral leads. Okay, so in other words, we expect 1 and AVL to give us a similar picture. And we're going to do some examples towards the end. Okay, So the chest or precordial leads, got V1, V2, V3, V4, V5, and V6, all right? So V1, V2 in the first, second, third, fourth intercostal space on either side of the sternum. V4 in the mid-axillary line, just a bit lower down. V3 then in between V2 and V4. V5 in the fifth intercostal space, anterior axillary line, and V6 mid-axillary line. The reason why I mention this is that I have seen a lot of people I've seen a lot of people actually place these leads too anteriorly. So what happens is you don't actually get a good look at the left side of the heart that's here. So the way your heart sits, your heart's a pyramid that's fallen down. So this is the base of the pyramid here, and then you've kind of got the point over there. And towards the front is the right ventricle, but towards the back is the left ventricle. So if you put V5 and V6 a bit too much to the front, you're actually not going to see the left ventricle at all. So remember that whenever you are placing your leads. Okay. All right. So what we're going to do, let me just hide this video panel. Oh, sorry, didn't want to hide that. I wanted to actually hide the floating controls. There we go. All right. So now we've got the heart, and basically we're looking at the top down. So you can imagine that we've chopped this person off from the head, and we're kind of looking down through the body there. So your belly button would be here at the front, your back would be there. All right. So that's how we're looking at it. So this is what we're talking about. So we've got the right ventricle, right atrium, left ventricle, and the septum. Okay. And then we see how our leads are orientated around there. So the same way that we had a circle sort of looping around the body, we've also got a sort of a circle, a semicircle of leads that are sitting over here. So what we're going to do is let's discuss each of these at the moment. Okay. So we've got V1 and V2, and these are called the septal leads. Now you may ask, why are they called the septal leads? Because they aren't actually looking at the septum, they're looking at the right ventricle. So what you've got to remember is if you look at the septum, it's actually quite large compared to the right ventricle. The right ventricular wall is quite thin, however, the septal wall is quite thick. So it's kind of like having two people standing one behind the other, and both are talking to you, but the person who's standing behind is actually shouting louder, talking a bit louder than what you are, than the person who's in the front, sorry. So what ends up happening is you end up hearing the person at the back. So that's why V1 and V2 are called the septal leads, because they end up actually hearing what's happening in the septum rather than what's happening in the right ventricle. Okay, so that's why we call them the septal leads. So we expect them to look similar. V2 is also called anteroseptal because it looks a bit at the anterior portion of the heart, not as much as V1. A bit more than V1. So that's why it's called anteroseptal. Okay, right. The anterior leads are V3, V4, basically, with V2 also taking part. So if we look back at that diagram that we had, V3 and V4 are looking at this area. So they're looking at the anterior part of the heart. So why is it important? It's because of blood supply. So depending on which of the arteries, whether it's the left main coronary or the left anterior descending, in this case, the left anterior descending, ischemia tends to happen along these edges, all right, or on this edge if it's the right coronary. So that's why we place the leads here to have a look at this wall and to see if ischemia is taking across there. So I can already tell you, let's go to V5 and V6. They form their own little group, and you can see they're looking at the lateral border. Okay, so they are looking at the heart from an from the lateral side. So we've got these leads now that are looking at the lateral side of the border. So I just want to draw something for you just so that you understand. So we said leads 1 and AVL also look at that side. So what's happening is we've got this image. If you can imagine a person and we're looking at them under their left armpit, all right? So we're looking at them under their left armpit, and we've got the leads that are sitting over there. What's going to happen is we've got V5 and V6 that are here. Let's rather put it in. Okay, so let's put it here. So we've got V5, all right? We've got V5 sitting there, right? We've got V6 sitting over here, right? So remember, we're looking at this patient now from the left. So we're looking at them from this point of view, from the left-hand side of it, all right? And then we've got AVL, okay. AVL, I'm putting it at the top because it's a bit higher. And we've got lead 1, okay. So we've got lead 1 that sits over there. So and behind this, we've got the left side of the heart. So let's put the left side of the heart over there. Let's put something like this. All right. Let's put that here. So this is the left side of the heart that we've got over there. And then we've got these, well, let's make it a little, well, I think that would be big enough. Sorry, I'm still, so we've got this left ventricle, or this left side of the ventricle. So we've got V5 and V6 looking at it from this angle, and we've got lead 1 and AVL. So we expect these 4 to give us a similar picture because they're all looking at the left side of the heart, just from slightly different points of view. So sometimes they don't always match up, and sometimes it's more the high lateral side that's affected, and sometimes it's more on this, on this plane of V5 and V6. Okay. All right. So I just wanted you guys just to have a look at that, just so that you understand it. So let's just hide this again as we're going through. Right. Let's hide that. Okay. So let's go through to the next part. All right. So as we said, V1 and V2, we've been through. V3, V4, and then V5 and V6. So they are called the lateral leads. All right. So basically, when assessing an ECG, we look at the zones, we assess the axis, the rhythm, the rate, and then the last thing we do is we go to the zones and we see. By following these steps, like I say, you'll find it easier to find the site of an abnormality. So let's try a few examples and let's see. So let's start first. So if you want to challenge yourself, you can pause it now, go through the entire ECG on your own, and you can see if the answers that you got were correct. Okay, and let's take it from there. So let's start first. So we've got lead 1 and lead AVF. Maybe we can just put our little drawing over there, just so that we can remember what's what. All right, so let's get this here. So remember, I'm just going to draw it off here to this side. All right, so we've got our little drawing to work out the axis. So remember, we have lead 1 and we have lead AVF. And we've got lead 1 that's pointing positive. So that means electricity is either on the left-hand side or in the normal. Okay, we know that it can't be here. Okay, and then we've got lead AVF that's also positive. So remember, lead AVF is at the bottom. So it's either there or there, but we already discounted it. So in fact, what we have is that we have a normal axis. Let's just leave that there. All right, so then we've got a normal axis. I'm not going to go through that in great detail again, just so that we can see. Let's look at the rhythm. So we don't have rhythm strips here, but what I can tell you in this one is, remember, look at the P waves. Let's hide all of this again. Let's look for our P waves. All right. So where do we see P waves? We notice that we don't see good P waves, but we have to look everywhere. Even though V2 is normally our rhythm strip, that doesn't mean V2 will always have it. So we can already see there's a problem. We don't have very good P waves anyway. So there's something that's happened to our atriums. So we can't talk about a PR interval. We can't talk about a QRS following every P. However, our QRS complexes are narrow and they're relatively regular, but we know we've got something wrong here. Then we look at the rate. I'll just work it out. 1, 2, 3, just over 75 beats per minute. Now let's look at each zone. So I'll take you through the system that I normally use and the way that I look at them. So let's look at the inferior leads first. So we've got lead 2, lead 3, and lead AVF. And what we notice here is ST elevations, right? So we've got ST elevations over there. So that means we're seeing some ischemia in the inferior part, right? So ST elevations normally signify ischemia. Let's go then to the septum. So we've got V1 and V2, and here we see ST depressions. These are ST depressions. So the reason why you get ST depressions, it's called a reciprocal change. Remember, where leads 2, 3, and AVF are sitting is on one side of the heart. So you expect things on the other side of the heart to see the opposite happening. So you'd expect to see some reciprocal changes, all right? So remember, reciprocal changes indicate that ischemia has happened. So the septum, we know, is showing us that the ischemia is probably real and where it's happened. V3, V4, the anterior part of the heart, we actually start seeing some elevations again. All right. So we're starting to see that it's not just the inferior part of the heart, it's actually involving the anterior part a little bit as well. And when we come to V5 and V6, again, we see that there's some ST elevations that are happening. So we've got the lateral side. And must remember, we have to look at leads 1 and AVL2 just to give us an idea of what's going on that lateral border. So we see in lead 1, there's not much, but in lead AVL, we actually have ST depression. That might be because AVL is sitting so high up that it might be seeing this almost from the opposite point, depending on where we put these. So we've got a whole lot of ST elevations. We've got the inferior part, we've got the anterior and lateral parts of the heart that are involved. And last but not least, AVR, which sits on the complete opposite side. So it's telling us that there is a lot of infarct that's going on. So this is quite a sick patient. The infarct has spread quite far. Now, if you were to say an inferior wall infarct, you would be correct, and it's extended all the way into the lateral side. As a rule of thumb, if the ST elevation in lead 3 is higher than lead 2, we say that it's not just inferior, but it's extended to the right side of the heart. And in the next one, I'm going to show you guys how we look at that. All right. So remember, your ST elevation in lead 3 is higher than lead 2. We say that there's a good chance that the right side of the heart is involved. Because remember, we've only got AVR looking at the right-hand side, but because of its placement, it may not always pick up ST elevation. So there's another way that we do that. Okay. All right, let's look at another one. And again, if you want to challenge yourself, let's try and do it yourself. The only thing I want to do, I just want to work out the axis for us. So let's have a look at lead 1. So we look at lead 1, and lead 1 is kind of biphasic to negative. So we know that if it's, let's say, negative, so we know it's moving away from lead 1. So we can't have a left axis or a normal axis. And we look at lead AVF, it's positive. So that means this is coming towards it, but we already discounted the normal. So we know for sure that we've got a right axis deviation. So what does that tell us? It tells us that we've got either a problem on the left side of the heart. So in other words, the left side of the heart has been damaged, or that the right side of the heart has become enlarged. Okay. So let's just get to that. So let's look at our rhythm first. So we've got some nice P waves over here. Let's look at them in lead 2. So we've got nice P waves. We can see them properly. Our PR interval 1, 2, 3, 4. So it's within normal. We've got a QRS after every P, and they are narrow QRS complexes that are regular. So we've got a regular rhythm, a sinus rhythm, and we've got a rate of 1, 2, 3, 4, say about 60 beats per minute just for now. Okay. Now let's look at each zone. So let's start again with the inferior zone. So we've got leads 2, 3, and AVF. And what do we see? We see an ST depression here. So we've got to keep that in mind. That means if we see ST elevations everywhere, we know that this is a reciprocal change. Let's go to the septum. V1 and V2. Here you can see massive ST elevations. So, and these, if nobody's seen it before, this is called a Q wave, but we'll discuss it further later on, okay? So this is a massive ST elevation, so we can see that this anteroseptal part is involved. And this means that this is a reciprocal change here. Then if we look at V3, V4, we can again see these massive ST elevations. So we're starting to get an idea that things are happening on the anteroseptal side. We come to V5, V6, 1 and AVL. So let's look at V5 and V6. Again, we can see ST elevations, and in leads 1 and AVL, we can also see ST elevations. So that means this infarct has not only involved the septum, it's involved the anterior and the lateral wall. So it's an extensive infarct. And these ones are just picking up the reciprocal change. In AVR, we see a bit of an ST depression because, again, we are looking at the inferior part of the heart. And this is now what we're going to tell our physician that's coming in, that we've got massive ST elevations that are present in the anteroseptolateral, or septoanterolateral, however you want to, but basically the entire left ventricle appears involved. So I mean, the left ventricle is what keeps you alive. So this patient has got a massive infarct. You can't go for T. This patient needs to be looked at, okay? So at least we know what to tell the person who's coming in. So let's look at another example. So we say anteroseptal, lateral. All right, not a problem. So this is a scary ECG. If you want to challenge yourself, pause now, and then let's take it from there. Okay, good. All right, so let's start first with the axis. So we see that lead 1 is positive. So let's get our drawings going over there. Right. So we see lead 1 is positive. So we know we've either got a left-sided or normal axis, and we see lead AVF is negative. So that means it's either going extreme right, but we've already discounted that, all right, because we know it's not going in that direction. So we've got a left axis, okay. So if you got that right, great, okay. Right, let me just hide that now. Okay, let's look at the rhythm. So let's start with our P waves. So we're lucky enough to have a rhythm strip here. So we've got nice P waves. They actually are showing up, and we can see they actually do look okay. They might be changing slightly from beat to beat, but that's something a bit more complicated. We're not going to get into it now. And then we have a look at our PR interval. We've got 1, 2, 3, 3.5 to 4. So it's still within normal. Our QRS complexes, however, are starting to look a bit wide. They're not 100% thin, but there's another reason for that. We're not going to get into it too much now, but for the sake of argument, we'll call them borderline for now. And we've got a QRS after every P, and it's quite regular. So for right now, we're just going to say we have a sinus rhythm that's going on. Okay, and our rate, let's work that out. It's 1, 2, just above 3. So we've got a tachycardia, so a sinus tachycardia. So let's break down what we see. So in leads 2, 3, and AVF, again, we see these ST depressions. All right. So we've got to look around and see what we can find. Okay. Let's go to the septum V1 and V2. Again, in V2, we see this ST elevation, and we see what we call Q waves. All right. So just to spend a minute on Q waves, a normal Q wave, let's see if we can get, I just want to show you guys a normal Q wave just so that you'll understand. So this, maybe, oh, here we go. So this is what we would call a non-pathological Q wave. It's short, it's thin, there's not much going on there, you know. But a pathological Q wave is something that's deep and that's quite wide. So we see pathological Q waves. Pathological Q waves basically tell us that ischemia happened. The problem is they don't tell us when. It could have happened 10 minutes ago, it could have happened 10 years ago, but it did happen. But for right now, we're not going to concentrate too much. I just wanted you to have a look at it. So we can see we've got ST elevations in V2, so we can see the septum is involved again. If we come to V3 and V4, again, we see these ST elevations over there. So we see the anterior side. We come to V5 and V6. Again, we just see these slight elevations, although not so much in V6. But remember, we've still got to look at 1 and AVL. So in 1 and AVL, we see that we've got quite big ST elevations. So it's starting to affect more the laterals, high lateral side. So that has to do with blood supply and branching, which don't worry about too much right now. So again, we've got one that's involving quite a big part of the left ventricle. And on AVR, we don't see too much over there. Okay. So if you got that right, well done. You did quite well. So anterolateral infarct. Okay. All right. Let's try another one and see what we can see. So this is a bit more difficult, but we're going to go through it. Okay. It's a bit more subtle. Let's say that. So if you want to challenge yourself, you can start now. You can pause. Okay. So let's go through the axis again. What have I done? Sorry about that. I actually wanted this up. So let's draw this. So we've got lead 1 positive. So that means we've either got a left-sided axis, we've got a normal axis. We know for sure we don't have a right or an extreme right. Okay, and let's look at AVF. AVF is negative, so that means it's moving away. So that means we've got a left-sided axis. Okay, let's just undo that for now. Okay. So we've got a left-sided axis. So that tells us that something's happened on the right-hand side, or the, the left side has grown larger. Okay, remember that. So let's look at our rhythm. So here we've got P waves. We can see nice P waves there. We can see a PR interval of about 3 blocks, narrow QRS complexes that are quite regular. So we've got a regular rhythm. Okay, and if we look at rate, we're looking at a rate of about 1, 2, 3, 4, 5, so about 60, so borderline to a bradycardia. And then let's look at each zone. So we look at leads 2, 3, and AVF. What we notice is these ST depressions. So again, we've got to keep an eye out of whether we have ST elevations, all right? So let's look at V1 and V2. And in V1, we see a little ST elevation over there. So that means this is most likely a reciprocal change, okay? So that means the septum might be getting involved over here. And V2, we don't see much. V3 and V4, again, we see reciprocal changes. So that means there's something happening on the opposite side of the heart, which means either the right side of the heart or the posterior of the heart, because remember, these are the anterior leads, okay? And in V5, V6, V1 and AVL. Let's look at V5 and V6. Again, we see ST depression. So it means something's happening on the opposite side to those. And we look at leads 1 and AVL. Again, we see a little ST depression there. So again, it's telling us something's happening on the opposite side. And when we come to the last one, we see an ST elevation in AVR. So that means we're looking at something that's happening in the right-hand side of the heart. Now, it's a more subtle one because most people remember, don't forget to look at AVR. And one thing I want to tell you guys is when you see this type of a picture, when AVR is elevated, you must be worried, okay? When AVR is elevated, it actually tells us that our left anterior descending or even our left main coronary artery are occluded, and it's very close to the proximal part of it. It's extremely dangerous. So don't ever forget this one. When you see this, your patient is in danger. And the truth is that these patients here, because they get a blockage so high up in these two main arteries, they actually have a 75% mortality rate, and that's when it's diagnosed. So when you don't diagnose it, you are actually got a 100% mortality rate. The reason why I mention this is because a lot of people don't look there. They see all these ST depressions and they call this an NSTEMI or non-ST elevated MI. In the meantime, your patient has a STEMI, and the workup and the management are completely different. These patients often have severe pain and then become normal. So they're actually sitting there next to you quite okay. And we had this on the group where I showed you guys that we were worried about one patient. The reason being that they denervate very quickly. The vascular supply to the heart settles down very quickly. I mean, is killed off very quickly. So that's why they end up having being quite pain-free, surprisingly. Okay. Good. So if you guys got all of that, I'm very happy, and I hope you've enjoyed all of these lectures. That's just a little joke to finish off. So there's one more to this that is called the acute chest pain. But what I want you guys to do is after you've settled and you've listened to this part of the lectures as well, and you are happy that you understand these basics, then we'll move on to chest pain, because you can't really understand chest pain until you understand these basics. Okay. So what I would expect is from those of you who have listened to these lectures, who have enjoyed them, and I hope you've enjoyed them, that you will let me know. You can direct message me that, you know what, we're happy, we understand the basics, and then we can move on to the chest pain so that you know what to do with chest pain when it happens. Okay. Thank you guys. I hope it was okay. And I hope you guys learned something from it. Okay. Thanks a lot. Bye.